Invest Africa, proudly brought to you by KPMG.
With me, I have my guest, Alex van der Heever, independent health economist, Dr. Noluthando Nematswerani, the Discovery Health clinical specialist, and Dr. Don Pupuma, a family physician. So now, during the break, we had a little bit of a tete-a-tete. No, Noluthando, you're very eager to bring in the 16 days of activism and how that, creates greater awareness. Let me allow you to do that before I respond with my own views on that.
I think it's more about saying women and children still remain vulnerable in terms of the fact that we've got a very high rape incidence in South Africa. So that actually exposes the women and the children to HIV.
I guess my response was that I would really appreciate it if we had just more than a short period or a month dedicated to such issues. And I sometimes feel that having a minister pronounce something once a month in a 12-month cycle is not as effective in my view. But yes, I do agree with you. That's possibly a very important strand of the conversation that we have to bring in. I also want to weave a little bit, and I want to go back to a point that Don made about the labor force. The people that are outside of the labor force. And I want to bring that back to you, Alex. I want us to talk about the labor-intensive industries. When an investor is looking at a particular African country, how strong an indicator or how significant an indicator is the prevalence of HIV/AIDS, especially if you're looking at a mining company or any other labor-intensive company that wants to bring some foreign direct investment?
Well, I think the issue to understand that's important is that it is not that the sort of the business side of investment is not necessarily impacted on negatively. There has been an excessive stress on the sort of the business risk associated with HIV, and there have been a number of studies on South Africa which I found very problematic. I think that the implications are very significant at a social level and in terms of longer term development, but in terms of immediate investment the risk is low. I think the important issue is not letting businesses get away with not helping people, not protecting them from HIV and protecting them when they're and providing them with access to services and information. But that does not impose significant business risk on anybody wishing to invest in South Africa.
Noluthando, how do you respond to that? And also in light of an earlier point that Alex made, that taking care of the actual employer, not their broader family, isn't actually making the impact that's required.
I think looking at from a discovery point of view, because remember, we service the whole family. So it will be employer.
So there's an exception to the rule,
yes,
I guess.
Yes, it will be the employee with the dependents. So
right.
You find that the spouse and the dependents, including the kiddies, are actually part of the whole program. So it's different for the uninsured, where the person does not have access to medical aid, and therefore it means the family is actually left out.
So I see Don has a comment, then we'll come back to you, Alex.
I think we shouldn't forget the role of the state in this. And the state has been a big driver of where we are, and in terms of progress and in terms of their targets for the country. And equally important, I think it's important to note that business ultimately pays the bill for this via tax. And therefore it is in big business's interest to make sure that HIV is contained, especially considering how much it costs right through the value chain, from testing through to lifelong treatment if someone slips through the cracks and lands up with HIV.
Yeah, the issue is that there are a number of people on programs, employer-related programs, which are not medical schemes, and often essentially private short-term insurance arrangements or some other kind of contractual framework outside of the Medical Schemes Act. The medical schemes are required to cover the whole family, but the employers, typically when they don't have to, don't. But and the insurance arrangements don't necessarily. So it is up to, but the medical scheme is not allowed to deny access. So that's where there is a difference. So that burden is then placed, shifted onto the state. And I think that the state has to carry a major burden of dealing with this. But I think that to the extent that employers only accept part of the obligation where they're dealing with their own employees, I think that isn't right. But government really is the major contributor to solving the problem at the end of the day.
I want to throw this back to you, Don, on the point of government. I mean, a lot of the gains that have been made in South Africa and other African countries, it's been said, has been on the back of PEPFAR and similar fundings from international donors. And we know that that funding is not a bottomless pit, and at some point it will be finished. Now, are we making the right decisions now from a policy perspective to ensure that should those funds and when those funds run out, that governments can actually continue with these programs?
I think we are. I think we're on track. A lot of interventions and a lot of targets, starting with the National Strategic Plan, which, for example, looks to halve the number of new infections that we get. I mean, just to put it in perspective, over the past 10 years, we've been having approximately 400,000 new infections per annum. Which is way too high. And government has set a target of reducing that to at least half by 2015. And the cost of that for the 2013-2014 budget is approximately 23 billion rand. And going into 2014 into 2015, we're looking at about 35 billion rand. That is a huge sum of money to expend on one.
But then again, there's that shortfall that's been identified. And I think I've picked up those figures as well. And the shortfall has been, against those figures, about 3 to 5 billion rand US dollars of a shortfall. Where's that money going to come from?
That's where
that's the golden question. Maybe, Alex, do you have some idea of where they can get the money from?
Well, the issue is that this is a question that always faces the country. To the extent that we've relied on a form of aid for an aspect of our recurrent funding for HIV and AIDS, we have to look at long-term solutions, because it's not sustainable it's not appropriate to expect that to continue. What we need to do, therefore, is to look at not only the issue of the effectiveness of the programs today in reducing the long-term liability, which we haven't done, which is bringing down the infection rates properly. In other words, that the programs actually work.
Right.
There's a lot of stuff happening, but it doesn't necessarily translate into stuff that makes a difference. It's just shooting in the dark. And then there is the issue of bringing down the cost of tests and bringing down the cost of drugs, as well as the overall macroeconomic impact of the drugs programs, which means that we reduce the amount that we're importing on this, because we've got such a large liability. We shouldn't be importing it, we should be domestically producing it. Plus the kind of risk reduction programs that do have a long-term impact, like vaccines, need to be looked at, because even if they only come in 10 years from now, they have a chance of having both a therapeutic effect as well as a reduction in transmission. And if that happens, we're actually substantially changing the liability.
Right. It's bringing you back in, Don.
There are a number of exciting developments, and I think it's important for us to perhaps even dwell on them. The most important being the recent adoption of voluntary medical male circumcision and what it can do to the pandemic. And as part of a bigger strategy, which we call combination prevention strategy, whereby we include the psychosocial aspect, which includes education, etc., and the biomedical aspect, which includes treatment. And in this instance, one of the more recent appreciations is that treatment is not merely treatment in terms of sustaining life, but now treatment has become a major source of preventing new infections. And when we have combination prevention strategies like circumcision of mobile males and just males in general, that should have a long-lasting impact on the pandemic.
Let me bring you, I want to bring you in, Noluthando, and perhaps before you respond to John, to perhaps also talk to us a little bit about the changing demographics on the continent, where we're moving to a much younger population, and how that might mean that we need to rethink the way we message our campaigns in terms of reducing HIV and AIDS. The way we're doing things right now, is it still going to be relevant 10, 20 years from now, when 65% or more of the population is all under the age of 20?
Sure. I mean, you're looking at people who are getting new infections, the younger population. I mean, in my view, the younger population is aware of HIV. So they are taking precautions, and you can see there is a reduction in new infections in the younger age group, but we still have in the reproductive age group some new infections coming through. So I think in terms of changing the strategies, yes, we need to start looking at HIV differently, but I think the messages have gone through and people are starting to understand in terms of prevention. But I think prevention also is a bit complex in the sense that not one single strategy can actually reduce the infections. So you need to really have a comprehensive package of these prevention strategies, which is something that I think all the countries are grappling with. And in South Africa, we are also focusing at looking at medical circumcision, looking at pre-exposure prophylaxis. And I think the most important one that has been included in the guidelines is really about prevention of transmission between serodiscordant couples where you've got a positive and a negative partner that are in a long-term relationship, to say give access to medication so that you can actually prevent the negative partner in that long-term relationship from actually contracting HIV.
Our final comments to wrap this up. Alex, if you could just comment first on the role of civil society and particularly NGOs in driving forward this agenda. We've seen, the Treatment Action Campaign getting a lot of prominence, but surely there's still scope to do more in terms of giving them the capacity and the space to play a bigger role.
Well, I think civil society has been absolutely critical in getting our programs to where it is today. We had a government that wasn't moving adequately on both prevention and treatment, and where we are today is to a large extent a consequence of non-governmental action. They are a crucial part, and I think that they have to remain. Essentially, people have to grab that space. It's not one that's given to them. They've got to take it. And
I've got less than a minute, 10 seconds, Noluthando. From you, if we look at the MDGs, 2015 is around the corner. What do you think that picture is going to look like? A good or positive picture?
It will be a better picture, but maybe not where we're supposed to be.
A better picture. Final comments from you, Don. Let's look at the coordinating the HIV/AIDS response within the country. Do you think that there's more that could be done in that space?
There's always more that can be done. And I'm thrilled to say that people interact, people are continuing to work together, and the government and civil society have begun to see the light and realize the importance of having no new infections within about 20 years from now, if we act together in unison.